Hello, everyone, and welcome to today's panel discussion, Health Justice in the COVID Era, as part of the Rethinking Everything COVID in the Americas conference. I am Sarah Swank from the law firm of Nixon Peabody. I work out of the Washington, D.C. office, and today I have two incredible panelists, and we're really excited to talk about this topic. Hector, why don't you introduce yourself to the audience?
Yeah, Sarah, Professor Irvin, it's really nice to be with you today and talking about this really important topic. So I am the High Impact Areas Director in the Opioid Response Coordination Office in the Tennessee Department of Health. And I am also a professor of global health in the Tecnológico de Monterrey in Mexico. And today I'm not coming to talk as TDH employee, but I think that is a really important topic to discuss. Equity in COVID times is something that I'm passionate about. I worked years in rural Chiapas with Partners in Health, and this is equity. I think this is exactly the kind of topic that we should be talking about in these days.
Thank you. And Dr. Irvin, do you want to go next?
Sure. So my name is Risha Irvin. I'm an assistant professor in the Division of Infectious Diseases at Johns Hopkins School of Medicine. I also serve as Associate Vice Chair for Diversity and Inclusion at Johns Hopkins School of Medicine as well. A lot of my work involves kind of health disparities and health equity as it relates to HIV and hepatitis C virus. And with the emergence of COVID-19 have now transitioned into a lot of work around COVID-19 health disparities and vaccine education in our community in Baltimore.
Thank you. So I have two incredible physicians here. I'm an attorney who feels very passionate about these same issues and comes at it with a different lens from around the legal framework, and even sometimes with the legal framework where these inequities still exist. So let's start with the basic question, which is what is let's start with Hector. What does health justice mean to you? And how do we even start this conversation around health justice?
Yeah, this is I think for me, when we talk about justice, is that instrument that we use to make sure that everybody, it doesn't matter where they live from, or it doesn't matter the race or the socioeconomic factors, they have a dignified and healthy life. And I think that this is, since the Alma Ata conference, we have been talking about this concept of health equity and social justice. And we even have said what we want the Alma Ata conference, it was all about health equity, multidisciplinary collaborations, and community participation. These were like the three different aspects of the Alma Ata conference. And we have been talking for a long time. And now what we're realizing with COVID is that we are really behind in matters of health equity across the world. How we have seen how the pandemic affect many, like much more, some communities compared with others. So this is what it comes to mind when we talk about health justice.
Risha, do you agree with Hector? Is that how you define health justice? And is there anything you'd like to add to that definition?
Sure. I think as we think about health justice, we have to start with kind of, what are health disparities and think about health equity. So when we think about health disparities, an easy way to think about it is a difference in health. But if we look at Healthy People 2020, it defines health disparities as a particular type of difference that's closely linked to socio-economic or environmental disadvantage. And so we know we have a long history of those in the US and in multiple places abroad as well. And then when we think about health equity, that's really the highest attainment of health for all persons. And so then when I think of health justice, it's how do we get to health equity and the things that we need to do to get to kind of a place where equity is the standard for everyone.
Excellent. So it's interesting. So if anyone's ever heard me speak before, and maybe a lot of you have not, there's some of these definitions that we're coming up with that are, some are longstanding definitions, and sometimes there's not words for what we're trying to do, or sometimes the words now, as I reflect back on them, feel a little light, right? So, and I'll give you an example of where I think it's a positive, which someone said to me, Sarah, you seem really passionate about health justice. Is that, how long, what is that? And like, how long has it happened? And I was like, I guess I've been doing it, what, for 15 years, or is it my whole career, or is it the last 6 months? I don't know, because it's a new term. And if we look at like health disparities or social determinants of health, there's a part of me that says, that's really interesting, but like when we say food insecurity, that's people like starving, they don't have a meal. Like, are we using the right words? Are they, health justice feels strong. Some of the other ones that are very common, almost, it's hard for somebody who's not working in the field to know what is the social determinant of health. So Hector, what do you think about that? How do you feel the language that we're using has evolved, and what are some of these definitions, and are they changing? Or is this all new?
Yeah, the technical definition is like we go health disparities, any difference that is like due to intrinsic factors, and then we have inequities, which is the distribution of health and the outcomes really, and then we have other terms. Now, when we talk about social determinants of health, this is the term that we have managed in the Western world, social determinants of health, and we have like housing, food insecurity, and we have like poverty, we have all these, and then at the end, these factors determine who gets sick and who doesn't. Now, the Latin American version of this is the social determination of health, which is, and really the difference is that social determinants tend to be very apolitical. They don't think in terms of political, economic, and cultural terms. It's like they focus, okay, when we think in social determinants of health as doctors, we think in focusing in housing and like going beyond, a little bit beyond the clinic. Social determination of health is how we modify structures of power that define who gets sick and who doesn't. It's not even related with healthcare. It's even beyond that. It's politics, it's economics, it's how we make decisions as a society. So it's really interesting. I think that's something for me is interesting because I have been part of like the social medicine movement in Latin America for years, and it's interesting to see how definitions are played in different ways by different societies. And I think that definitions are evolving. I think my fear is that sometimes as we move forward, we forget about that political and economic aspects that determine how we distribute PPI or how we distribute vaccines. Or sometimes also we forget about what is going on in other countries like Malawi, like Rwanda, like all these countries that are experiencing like high tolls of COVID related deaths. Actually, Rwanda is a bad example, but other countries that are experiencing high tolls of death. So that's what it comes to mind, Sarah.
Great. And Risha, how do you feel about the definitions and whether you think they're evolving, and do you have any opinion about the evolution of those definitions?
Sure. I think over the last, decade or so, we've had kind of an understanding of kind of health disparities and what we've seen in kind of chronic conditions and infectious disease. And that I feel like lingo and language has been used in the healthcare field. What I think now is happening is a kind of a broader understanding of many of these issues for both the public, but also for the healthcare industry to take a more broad view on these issues when we think about health disparities, health equity, health justice. And so I feel like we're becoming a little bit more encompassing in our definitions to include a lot of the structural issues that some didn't recognize that play such a huge role, I think. And so I think that's a good thing. I think in the US, a lot of the racial unrest that we've had over the last year or so has played a big role in that, and people thinking about the structural issues and how that impacts issues across the board, not just in healthcare as well. And so I think we're coming to a better understanding of these issues, and I hope that that continues and we continue to grow in terms of what our research is, but more importantly, what our response is to these issues.
So, Risha, one of the things I was thinking about, like this is pre-COVID, was when I personally went to go look at some of the numbers around women in pregnancy. and thinking that I was going to find this like more global like epidemic, and then realizing it was here in the US with especially Black women when we looked at the data that we had, whether that data is enough, but we'll talk about later about data, but that was really impactful to me, to see that if I wanted to go volunteer or work on those issues or think about those issues, that I did not have to look much farther than my own country to look to see that. And it wasn't just some bad health outcomes, it was life or death. And it was quite, even for somebody who has worked and cared a lot about these issues, it was really surprising. Do you have any comments on that, or this is all going pre-COVID type data and information?
Sure. What you're saying is absolutely right. And I think, a lot of people didn't realize how kind of bad some of the health disparities are in our country. I think, a lot of people view the US and say, oh, we have great healthcare, but don't know a lot about the data, and that we have a lot of, in particular, race and ethnicity disparities in our country, almost across every chronic disease and infectious disease, like I mentioned before. One of the big ones is maternal health in pregnancy, in particular, like you said, around kind of Black women and health outcomes and kind of death. And what that means in this country. And I think, everyone that hears that should be outraged and say, what can we do? There should be ownership amongst the health community to think about what role we play and how we can impact that. But I think more broadly, in the US and abroad, we have to think about issues like this across the board and think about, the things in the healthcare system that can be improved, but the overall structural issues that can be improved, both inside healthcare and outside, because ultimately to see these outcomes change, I think there's going to have to be a lot of broad changes that happen in the kind of healthcare and outside of it, so that we see an impact on these health outcomes.
So Hector, hearing what I just said, and what are from your vantage point, and you have a couple vantage points, what have you seen? I mean, I picked maternal child and in America as a particular condition, but and how it really is, like when you look at the numbers, it really is life or death, and there are people going to potentially to the same hospitals or different hospitals, or maybe not having access to a hospital. We can dive into some of the. I hope we raise some issues, and we're also going to talk about some solutions here today too. But so Hector, what would you like to comment around that?
Well, even before COVID, I really like what Professor Irvin was mentioning, because even before COVID, to paraphrase Louis Pasteur, he would say that the terrain itself was already virulent. So, for example, in Mexico, we have huge health inequities. We will see that a kid living in rural Chiapas is 6 times more likely to be malnourished compared with a kid in the rest of the country. So now if we go to other chronic conditions like hypertension, diabetes, we know that premature mortality, it happens mostly in the developing world. So now we know that all these malnutrition and chronic conditions are risk factors for COVID. And if we come to the US, we know that 40 million people live below the poverty line. It's the most obese country in the world. 87 million people are under or uninsured in this country. So I think that all these factors that determine how we respond to or how the outcomes are going to happen after a pandemic, we're already there. So I think that what COVID has done is just like highlight all these things, all the social pathologies of our nation came to the forefront with COVID, and it has been the same pretty much in many countries like Mexico, for example. That is where I'm from.
So Hector, one more thing about this. So you're kind of talking about, so this is pre-COVID. We knew those issues existed. We had terminology around them. What were some of the solutions pre-COVID, and have they changed post-COVID? Are you looking at it in a different way? We know, we talked about some of the the social systems that are happened and got highlighted in the United States, like our criminal justice system, and how that created at least awareness, hopefully, around how that might intersect with healthcare or just generally systems. So what were some of the solutions, Hector, that you were seeing, and do you think they still translate post-COVID?
I think that one of the big solutions is we have to invest more in health. And when I say, sometimes we confuse investing in health with investing in healthcare. I think that health systems should be enabled to also work with determinants of health. And I think that this is something, there are already some systems working on that. When I was in Chiapas, we'll have in Mexico a community health workers program. They were kind of like social workers that will accompany patients to the clinic visits, or they will like provide medications at home when they like miss an appointment in case that they have a chronic condition. I think that there are so many innovations that we can do to provide care in a way that is more humane and is more across the continuum of care. In that sense, for example, I work with addiction here in the US. I'm directing the largest program in Tennessee against opioid addiction. And what I have realized is that there is the programs that do prevention are separate from the programs that do early detection. They're separate from the programs that provide treatment. And then it's just like multiple vertical interventions without cross collaboration. And I think these are the things that we have to really coordinate, because when we think about COVID, we have to think of the system being coordinated to prevent the disease, to diagnose, and then contact tracing, and then quarantine and isolation and all that. But the system has to be prepared for that. Now, when it comes to poor countries, developing countries, I don't think we're investing in health enough. Mexico is investing around 6.7% of the GDP in health, which is way below the rest of the OECD countries and many other countries in Latin America. I think we have to be investing more in health, but investing more in health in a way that it makes sense. In the US, you have a system that is disarticulated and multiple providers, multiple mechanisms of financing. I think that a system like in other high-income countries with better performance will make more sense in the US.
So, Risha, let's talk a little bit about some of the interventions that were happening prior to COVID and whether some of those solutions still make sense. I mean, one of the things Hector's talking about is this idea of navigation, and we saw some of that kind of care transformation happen after the Affordable Care Act passed, and we were actually changing how people were compensated under the healthcare system. To try to break down some of those silos. What are some of the solutions that you saw pre-COVID that may work post-COVID?
Definitely. So I think one of the first points I want to make is that what Hector talked about is investing in kind of health and public health should be a big priority. I think for a long time we underinvested in public health and prevention, and ultimately we see a lot of these health disparities across the board because of that. So I wanted to say that first. I do want to make the point again that I think, we've had a lack of investment overall in kind of public health and prevention. And so many of the things that we see in terms of health disparities are related to that. In terms of kind of interventions pre-COVID that I think also apply post-COVID are really taking things to the community. So we've done a lot of that with HIV and hepatitis C, which is kind of where I primarily worked pre-COVID, in terms of, we see a disproportionate impact, particularly on the African-American community in the United States. And so how can we kind of improve that? So one is identifying who's positive for HIV and hepatitis C so that people can get treatment, but not expecting people always to make it to a clinic to get tested. How can we reach people where they are in the community? So going out on vans, for instance, and kind of advocating for testing and educating people. And we've also transitioned that model to use in COVID as well. So I think that's a big part of it. The siloed structure of healthcare is also a big issue, that you see your primary care provider, but you've got to be referred multiple places for other types of healthcare. So I'll give you an example for hepatitis C. What we've done is try to train primary care providers, substance use providers, HIV providers to treat hepatitis C. So if their patients are positive for hepatitis C, they don't have to refer them out to another provider. And if the patient already has a relationship with a provider they trust, then they should get treated there. So moving hepatitis C care into their primary care home, into their substance use treatment center, into their HIV treatment, and not having to go to a different place so that we're not so siloed. I think, again, we can use those models as we think about COVID-19, but even beyond that, how can we integrate healthcare for patients and make it just an easier process for people? And so I think that's where we really need to be.
One of the things I think about, because I've looked at the fraud and abuse laws and worked within these laws around transportation. And it used to be, for example, hospitals providing transportation for people who may be honestly going in and out of the emergency room and feeling like they're just, you watch them leave and you think they're going to be back, and like they're getting lost in the system, but we can't even give them a taxi voucher to get to wherever they need to go. And what really hit me was the first thing I thought about when I thought about vaccine distribution was transportation. And also having done launched a lot of telehealth programs and advised on telehealth programs, was also that idea, this brick and mortar idea. A lot of the changes that have happened were spurred by being in a national state of emergency. And for example, the 1135 waivers from CMS that allowed payment from Medicare that was funded by Congress. And so there's a couple of things that I think about. We'll talk about telehealth and transportation next. On the telehealth side, this idea that you would, I give this example being partly facetious, but it's actually true, is like, in an urban area, if you're lucky enough to have transportation to get to where you're going, because there's always the last mile problem on either side in a lot of urban areas, but assume you could do that. You get to either sit in traffic or sit a long way on public transportation to have your blood pressure checked in a primary care doctor's office while your blood pressure is going up. And then you get to wait in the waiting room while your blood pressure is going up. Then you have your blood pressure checked. And then you get back into that same traffic situation or public transportation situation and go home. And there could be just such an easy solution, which is allowing home monitoring of something like that, which we're seeing the idea of that maybe expanding. So I say that kind of facetiously, but it's actually a true scenario. I know, for example, with opiate treatment, there is certain times that people would previously have to go into an office. And a lot of times in certain settings, it could be a rural setting, it could be urban setting, you're trying to work, maybe you're trying to take care of your kids, maybe you're trying to fit in this trip to the doctor for this check-in. So Hector, how have you seen COVID change those protocols?
So, Sarah, what you were saying, it reminds me, when I was working in Chiapas, we have people, there was like these rural clinics, and there was some people that would come from far away, and the only way to make it to the clinic, it was on donkeys. So we have to include in the community health workers program these donkey fees. And at some point, they become a large part of the budget, because we realize that without those donkey fees, people won't come to the clinic. So I think that this is just and when I think in what we're experiencing here, every time that a person, unfortunately, a lot of resources, and what I have seen, I have only like less than 1 year working in this program in Tennessee, but I have seen that a lot of the resources are spent after the people get an overdose. $40,000 in average is what it costs to treat somebody after an overdose in a hospital. You get the treatment, you get like stabilize the person, and then you make a protocol for like discharge and all that. So I have seen that in COVID, we are trying to do more innovations in that sense, and it's like the same idea of the donkey fees, how we make sure that people now that are experiencing isolation, like some mental illness on top of their really like addiction, how we make sure that these people have all the support that they need to reach our clinics for treatment services, how we make sure that these people have food, how we make sure that these people have insurance. Around 40-60% of the people that we see after an overdose, they don't have health insurance. So this is a really struggle. Now people without a home or unstable housing, this is a big part of the population that we see also in the state of Tennessee with opioid addiction. So I think I don't think that we have an answer, but we're still trying to find ways to support these people in a way that it makes sense for better treatment outcomes.
Talking about telehealth and transportation, Risha, do you want to give some examples or your thoughts around those two concepts?
Sure. I think the biggest thing is giving patients options so that people can use, what works for them. And so I think, the funding that allowed us to use telehealth as an option, I think was just really helpful. For my patients, I sit in a hepatitis C clinic. And it made it much easier for many patients across our state of Maryland, for instance, to have an appointment, even people who are local, but like you said, trying to fit in the doctor's appointment between work and taking care of their children. And it's getting there, your transportation, if you're driving, having to park a car, having to pay for parking, then getting to the clinic, like all of those things are barriers. So giving people the option. So I've had some patients that really love the option of telehealth for some of their visits. There are times that they want to be seen in person as well, but they have the option. And so I think that's the thing that we should take from this, is giving people the options that they need. We do also have to think about kind of transportation, like you said. So whether people are driving in a car or using a public transportation. I know in my area, for instance, it's really hard to get places. And so, oftentimes people will take multiple buses. If you miss one, it throws off the whole schedule. And so we'll have patients call in and say, I missed the stop. There's no way I'm going to make it in time for this appointment. And so I think giving patients options and being flexible for patients is just where we need to be and how we need to think about things.
So with that, one of the things that you said, Hector, really resonated with me, which is I've heard this before, which is the idea if the patient's gotten to the hospital, it's like we've already failed. There's some reasons to go to the hospital, right? And there are good reasons to be there. But there's a lot of people where it's it's sort of like it's like it's not even just the healthcare system. It could be multiple systems have failed them. What do you think about that, Risha?
No, that's so true. I think, there's a lot of things that we see people in the hospital for that we should look at it as a failure, on ourselves and our system. My husband's actually an emergency physician. And unfortunately, a lot of people end up in the emergency room because they have no other place to go in our healthcare system, because there's so many gaps and loopholes and people who aren't covered, or, have some type of health care, but don't have kind of full primary or preventative care. And so a lot of things that we see in the hospital where people have progressed in a disease state is because they didn't have preventative care. And so if we invested there, we could avoid a lot of these hospitalizations. And I think we have to think about incentivizing our system in that way. But the way that it was built, and I think, Hector touched on this before, how disorganized and fractured it's been, that's not the way that systems were compensated. And so we've never made that investment in preventative care. And so people end up in the hospital for reasons that they shouldn't. And, it's not just, I think Hector made this point earlier, the healthcare system, but all of these structural issues, in the US in particular, when we think about, racial segregation and kind of where people live and what's available to them in terms of, is there a hospital or healthcare close to them? What kind of food is close to them? Are they in, a food desert where you can't access healthy foods, or do they cost more? All of those things, as well, we just have never invested in fully. And so we see poor health outcomes because of that, unfortunately.
Hector, would you like to respond to that?
I don't agree 100% with what Professor Irvin is saying. I agree 200% with what she's saying. I think that this is exactly where we're missing, because I see that we spend a lot of money to cure people, but to prevent disease is where we fail. And I think that the problem, let's go back to a country like Mexico. just 25% of the entire health budget, it goes towards two diseases, diabetes and hypertension. This is pre-COVID. And most of this money, it goes towards like taking care of people after they have a lot of complications. Like they have a kidney failure, or they have like I don't know, retinopathy or something, like complications of their diseases. So now we know that diabetes is like any death of diabetes is something that we could prevent. And we could prevent if we start thinking in terms of how we do policy that it makes sense. And Virho, this Russian doctor, used to say, well, it was like former Soviet Union before, but he used to say, doctors are the advocates of the poor. And he will say politics is medicine at a larger scale, which means here is that actually when we think about politicians and policies, this is what it produces health, and this is what it determines who gets sick. And this is all about allocation, how you invest resources in a way that you create a healthier environment. So I think I agree totally with what Dr. Irvin is saying. I think prevention is something that we haven't put a lot of attention in public health and in medical care.
So it's interesting because the next wave of, and here's another word we're using, which is digital health equity, right? This concept, it's my next thing I'm wildly fascinated about, because if we really are going to have telehealth and other digital solutions, not just telehealth, we're going to have those stay. They're going to stick, which is, I think, could be a real positive, another tool, right, of being able to care, and a lot of progression in that area. A lot of it obviously spurred on by a change in reimbursement, Hector, right? Not just the care of the patients, but also because we changed how people were paid, which was helpful to open it up. But this idea that we now might have equity issues around our new solution. And so, for example, cell phone and broadband, there, just as there are urban and rural deserts around food issues, there are, and I would love to see a map of this, but there may be an overlay around access to broadband and access to cell service that are deserts out there as well, that may actually it might actually become a social determinant of health as we move into a new digital era. We don't want to leave anyone behind, right? So Risha, why don't you go first? What are your thoughts about digital health equity?
Sure, it's such a important area, and it's something that we've had to think about a lot in terms of our COVID-19 health equity strategy. So one, just internally at my institution, in terms of getting people to sign up for the vaccine, you have a lot of staff who may not even though they may have access to email, they're not working in jobs where they're sitting at a computer. And so kind of we had to think about what was our strategy to make sure, one, that they were alerted, that they were eligible for the vaccine, that they were receiving vaccine education, and that they were able to sign up. And so a lot of that took, different ways to kind of think about how we could get messages out and make sure that people had settings where they were able to access the internet consistently in the setting of their job. Outside of our institution, we've also had to think about this in terms of digital health equity in a way that, when the vaccines initially rolled out, many states in the US, the only way you could get signed up was via a computer. But that leaves a lot of people out of the equation that didn't have access to the internet or their own computer, or kind of, just being able to obviously even navigate it as well. So I think we have to continually think about how we make sure people have access to these services, particularly if we're going to move into a world where telehealth is an option for people, but people have to have, the access to be able to use those things. And so we can't leave a part of the population behind, because then we'll still continue to see health disparities. It's great to have options, but we have to make sure everyone has those options. And so I think this digital health equity is really important in that way, to give people options, but we've got to make sure it's very broad, and that, we expand to a lot of these deserts that don't have, internet connections or kind of broadband. And I think we've also seen that in school systems that have been virtual throughout this year. You've seen children, sitting outside of restaurants trying to get access to the internet so that they can be engaged in their classes and have access to their classes. That shouldn't happen. And I think, again, we should all be outraged that that is occurring.
Hector, how about you? What do you think? Like I said, it's the new thing I've been thinking about, because I feel like it is the next wave of creating the haves and the have-not in healthcare. It's such an opportunity to open it up to everybody, but it's also another way to actually create a bigger divide. What do you think about that?
I think that we should have a conversation with Sir Marmot, which came with the idea of the social determinants of health, to include that in the original framework of the social determinants of health. I think definitely this is because right now, here is Tennessee, we have vaccines. We're receiving around like 90,000 doses every week or more. But the thing is that at some point, Latinos were 30% of all the cases of COVID in the state. That was in July. And they only account for like 6% of the population in the state. And Nancy Krieger and researchers at Harvard have been saying that Latinos from 35 to 44 years old are like 9 times more likely to die from COVID than whites of the same age. This is crazy. Now, when we talk about vaccines, we'll like, assuming from an equity perspective, we'll think that we'll make things easier for Latinos to register to have the vaccine, because they're dying more than other people from an equity perspective only. But now what we have is an online form that is all in English, where people need to have a computer, need to have like the language skills, and need to click a lot of things to make an appointment. And then you have to put like insurance and IDs, and so it makes things so complicated. And it would be much easier just to open something in a market or somewhere, a restaurant, and just vaccinate people there. The vaccines are free. You don't have to really pay. You just have to bring your ID probably to prove your age, but that's all. So I think that we are making things complicated for some people, and this digital health equity, I think that this is something that we have to make sure. All depends. If we want to serve everybody, we have to make sure that people have the skills and have the tools to be able to use health resources in a way that makes sense. Now, when we think about opioid response, we have been thinking about that like online and telehealth for the people with addiction disorders, and it hasn't been easy. It hasn't been easy. Doctors, sometimes they don't want to prescribe somebody who they don't know, like personally, physically. And also the patients, sometimes they don't have the technology and they don't have the skills to do that, to do an appointment and then to show up and then do it like in the right way. So no, definitely, I think this is something that we have to put a lot of attention, because we have to democratize health literacy and digital technologies for health.
So one of the things we've been hearing a lot about, I'm going to talk about vaccines for a minute, which is that the BIPOC community is not interested because of, like, you hear both sides. One, like a long history of mistreatment. If you look at like clinical research, for example, in the US, and that's the reason. You also hear people say, well, why are you, like, there's other people not wanting to get vaccinated, and we're not addressing that either. Like, there might be a mistrust of government, or, like I've heard there's been national security. There's been National Guard, like worried, like, if I don't want to get by the National Guard, or I only want to get by the National Guard, or I hear miscommunication from the government. So how do you address that with a lens of health justice? Like, what is your response to all those different viewpoints? Risha, I'll have you go first.
Sure. So, I think what I've seen in practice is that some of the issues about vaccine hesitancy, particularly being tied to African American or Latinx community, to me has been a bit overblown. There were a lot of, kind of research before the vaccines came out that quoted, very high numbers about distrust in the vaccines. And don't get me wrong, I think there is legitimate distrust in communities about science and about kind of the medical field. So that's real. But what we've seen as we've kind of rolled out, I'll say, across our city and state, in terms of talking to people about vaccines, is that people had questions that they wanted answered. But many of them became comfortable after they got those questions answered. And as medical professionals, we can't just say, oh, well, these people don't want it, or public health professionals, these people aren't going to want to get it. What we have to do is meet people where they are and be willing to have open and honest dialogue about people. This was named Operation Warp Speed from the beginning. So a lot of people had hesitancy and distrust just about it, how fast they were developed. So it was important that we communicated to people that a lot of the science already existed and was being used in other places. And so this just kind of brought people together to work on it together. But we have to actually explain those things to people. People wanted to know in a lot of our forums that we've done, who was in the studies? Were there people that looked like me? Were there African-American and Latinx people in the studies? Were there people with diabetes? And so people wanted to have those questions answered. And so I really think it's really on us to get out and educate people. So then people can make an informed decision about kind of vaccines and whether or not they want one. But to me, the biggest issue has been access for people. We've seen, locally, both in African-American and Latinx communities, that there's been a huge desire to get the vaccine and access has not been there. There were some large vaccination sites opened up, but those weren't sitting in African-American and Latinx communities. So the same issues came up in terms of transportation and kind of other issues with digital health equity. And so, there's been a big push to make sure in terms of health equity that there are sites in communities of color so that people can have access. And so I think it's important to have conversations about hesitancy and about historical distrust, because a lot has taken place in our country and abroad in the name of scientific research and medicine that shouldn't have. And we have to be, honest about those things. But we also have to be very kind of open to answering people's questions and understanding why they need those questions answered, and make sure that we're providing access to people and not writing them off as not wanting a vaccine.
Thank you. Hector, one of the things I've been thinking about as an attorney is I look at the state executive orders, and it's like you have your vaccine card and you get to do a lot more, right? This is something like you have more freedoms. You may be able to go congregate with other people in their houses, or maybe someday you might be able to get on a plane and so it's not even just health equity in the numbers, but it may actually have a real impact on what you can do in your daily life beyond healthcare. What do you think about that?
Well, I think that this is the whole idea of the vaccines has like immunity, like passports, is very controversial because I think that we are like, we know that there are less barriers for like people from like higher socioeconomic status, from like some ethnicities, to get the vaccine if they have a chronic condition for many reasons. I talk about Latinos, but I think that Black Americans encounter the same challenges. I also, as part of the Department of Health, I used to take calls from Latinos in Spanish, and I would find a lot of barriers about just to get the test. Like the job, the employer wouldn't allow people to go to miss a day to the test, or if they wanted to go in quarantine because they had an exposure, that also it was not easy because their job didn't allow that. So I think that there are so many barriers. Now, if we're making now for vaccines, people who receive vaccines, we're doing these immunity passports again, and people are able to go back to the normal life and to go to work and to go out and all these, and even like pursue economic activities that they used to pursue before. I think we're creating another division. So it's really funny because at the beginning we used to say that COVID, it was the great equalizer. And that was at the beginning because it was affecting everybody equally. But there is no in history a single pandemic who has been the great leveler. All the time, usually underserved people, like before, like after the pandemic, is even worse. And I think that if we do that with the vaccine, it's also going to affect some people more than others. And I think that that's a way to create some privilege for some and create some disadvantages for many. And I don't think that will work in the long run.
So we're talking about what's happening in the Americas, and one of the things that struck me is We like in America, we'd like in the U.S. we'd like to think that we do have more resources and we have more technology and we have excellent physicians, and but then when we hear about some of the disparities that we're talking about, we don't sound much different than other countries. Hector, do you want to comment on that?
A few days ago, I was reading an article on of all the 7 billion vaccines doses projected for this year, around 53% of them were already taken by the high-income countries, and they only account for 15 to 18% of the world population. In the meantime, the rest of the world have to make it with that 50% of the vaccines. So how do I feel about that? I think that's wrong. I feel that every single person anywhere in the world is a trillion opportunities for the virus to mutate. If we're thinking just in self-serving sense, and any mutation in the virus can come back and affect the US very quickly, just as it happened in China at the beginning. So I think that we have to be thinking in equity terms, not only because it's the right moral thing to do, but it's also for a security standpoint is the right thing to do. When you have a country like Canada who has 5 doses per person, then we have to question that, because I think that the US have always praised democracy, and we have to be democratic with the vaccines. The fact that we have more resources, it doesn't make us unique to receive all the doses and congregate all the doses. I think we have to make sure that other countries receive, and if they're not going to receive the vaccine, we have to make sure that technology is available to be replicated by these countries so that they protect all of the population. I think that's the right thing to do.
So, Risha, we are in a global economy, and part of my understanding, I'm not a doctor, but my understanding of the spread was because of our global economy and the transportation that's more accessible. If we look at H1N1, my understanding that was a mutation that was out there. So, what are some of your thoughts on what Hector said around this kind of global perspective on vaccination and disease?
Yeah, so we really have to think about our world as being interconnected now, because people can hop on a plane and be anywhere, really within a few hours. And so, our health depends on humanity. And I think we have to start viewing things that way. We've been so used to thinking about things as our country and our borders, but that's just not the way the world works now. COVID-19, for instance, was spreading probably months before, we really knew about it, because people can be anywhere in the world. And so I think it's not just, what we should do, but we, have a moral imperative to think about other people and not try to use all the resources up just for our country, for instance. And I think that's going to be very important as we think about vaccines, because again, if you only have people in high income countries getting vaccinated, COVID-19 will continue to spread in other parts of the world, and it'll be right back, in your country. And so everyone, I think, should be concerned about this. And I think we should also just recognize our shared humanity and want, everyone to do better. And so, hopefully, COVID-19 has started people to think about the world in that way, because I think, there have been pandemics before, or just kind of other diseases that have hit other parts of the world harder. And unfortunately, I think it hasn't brought us to that place where we think about our shared humanity. But, after being in lockdown a year, I do hope that people start to, really think about it that way, because, our health is going to depend on it.
So one of the things that I've been thinking about is the idea that public health is not new, but it might be new to a lot of people to hear about it, right? So the public health standards we hear, a lot of people, because we have been in a lockdown, have heard these standards like quarantine. We didn't, a lot of people, those were all new terms. And so it felt new to a lot of people, like wearing masks or getting prioritization of vaccines. And it's not that we didn't have pandemics in our lifetime, because we have, they just didn't create this this shutdown in this way. And having done preparedness as in-house counsel at a hospital system in DC, we had prepared for something like this. And when I watched our offices, we have a global law firm, I watched our offices in China close down, like a pit dropped in my stomach. And it was, and I'm not a public health worker, but I knew what the protocol was. And so, there are people out there that are quoted to say that we're probably going to see maybe up to 2, if not more, of these or something like this in our lifetime. Are there any lessons to be learned from the public health perspective, and especially with this idea of the lens of diversity and health justice? And I'll give you one example to think about, and then I would love to hear from you, which is something I was thinking about, which is the crisis standard of care, where when there are limited resources, physicians have to decide sometimes almost who lives or dies. In this case, it could be, for example, like who gets the ventilator and who doesn't, and there's a protocol around that. And then thinking, yes, but if the data that you use to make those decisions are flawed, isn't that like on race or other or other factors that are social determinants of health? Then are those decisions even are they correct or not? I don't know the answer to that because I'm not a physician, but just something to think about. So even something that we know is supposed to be part of the methodology in which we do public health, which is at some point you get to a crisis standard of care and there should be a protocol around it. Viewing it with this new, it shouldn't be a new lens, but this new lens gives you kind of a new insight or something that we maybe should do better next time. Hector, why don't you go first? Is there something around public health that like a lesson learned?
I think that I was when you were talking about this public health like race in the public's mind, I was thinking that public health people and doctors became kind of like celebrities during COVID. I would see like Dr. Fauci all the time, and people were like so happy to have Dr. Fauci talking. In Mexico, we have also the one of the under ministers of health, Dr. Gatell. He was like so famous. Every day he was talking about, this notion of like popular education, like teaching the masses about concepts of epidemiology that I learned in my master. And I think that here the message is we have to keep the same level of intensity and the same kind of like popular education for the masses to people and public health concepts. We have to keep it beyond COVID. I think that now we're talking about COVID. In a decade, we're going to be talking about climate change again. We're going to be, okay, how we solve chronic conditions when we have these climate change there, how we approach, how we make sure that every person behave in a way that it makes sense to reduce greenhouse emissions. So I think that we have to keep this campaign going for other conditions. I think that this is really important. And also something that I have heard of my friends is like they went to Twitter and they went to Facebook and they went to advocate for like COVID and conditions and to explain people because COVID. And I think that we have to keep that. I think that this dialogue between communities and public health experts and medical practitioners is something that we have to keep going. Of course, there are so many lessons. Other big lessons there is we have to invest more in health. We have to invest more in training public health people to get the skills that they need to approach issues like COVID, but at the same time, issues like addiction, like diabetes, like malnutrition, like poverty as a social disease. I think we have to be training our health professionals in a way that makes more sense for these new challenges of the 21st century and not keep using all curricula that we have been using for the past 15 years, like these episodic encounters of patients in hospitals with doctors. We have to change that.
So Risha, as we get to the end here, we have the idea that the pandemic ends. Like I remember when the pandemic first started, somebody reached out to me and said, "Does this end?" And I said, "Yes, H1N1 started in 2009. There's a date that it starts and a date that it ends." But looking towards that kind of optimistic look of it will end, what do you want to leave the audience with? What are the notes of that you would like to leave them with and to think about?
Yeah, so I think, we have to look at this pandemic is that, we will emerge from the pandemic. We still have to do what we need to do to get there. And that there are also diseases that we know how to contain. So, for instance, we deal with flu every year. We know how to contain it. We get a flu vaccine. And so we have to think about, we don't know exactly what the model will be right now, but we will emerge from this. I think what we have to think about is what lessons we learned from this. And I think a few things that, prevention is important. And again, we have to invest in prevention because what we saw is that having comorbidity put people at higher risk for, death from COVID. And as other pandemics emerge, that will emerge as well. In terms of kind of public health, we also have to remember to invest in public health. And I hope we take that lesson because certain things like being able to stand up a testing system quickly across the country only happens if you have a strong public health system. Contact tracing only happens if you have a strong public health system. And those things took us a while to actually get off the ground in the US because we didn't. So I hope we take those lessons through every challenge, I think, in life. There are things that you can learn to make things better in the future. And so I think we've learned a lot from COVID-19. And we have to now say we're going to take those lessons forward and make our system better.
Hector, what would you like to leave the audience with?
There is in 2001, the first World Social Forum was held in Porto Alegre, Brazil. And the motto of that forum was "Another world is possible." So I think that we have to be thinking in those terms. We have to be thinking in how we make sure that we have a new world for coming generation, a world that it can deal with climate change, a world that it can deal with threats like COVID, but also with potential nuclear crisis and so on. I think we have to be thinking in those terms. And I think that is a really good opportunity to remember the wise words of Mother Jones, a labor organizer at the age of 88, in her autobiography. She said, "It is time now to pray for the dead and to fight like hell for the living." I think this is up to each of us to be fighting like hell for the living, for the people who remain and also for the people who is coming, so that COVID crisis don't happen again.
Great. Thank you, Hector. I want to thank the audience for joining us today. I think I can speak for my other two co-panelists here. We really want this. We've been in unprecedented times, to say the least, and there's real suffering happening out there. And so I would hate for us to leave this time without taking the opportunity to better our systems. And just even the idea that we can have this conversation today, I think it's a start. It's not the finish, and it should definitely not even be the middle. And I hope that you out there are out there having this conversation, because from my perspective, this is how policy changes, is listening to people who are on the ground working through these issues. And I hope that you hear this and keep talking about it. Thank you, everybody, for joining us. Thank you, Risha, and thank you, Hector, for joining us today.